So we focus on understanding the needs of the community and the deficiencies in healthcare delivery at the refugee clinic, but also at the other community-based organizations, and we develop programs to cost-effectively fill those gaps in care and promote health. So not just treat disease, but promote health also. So we've kind of become an umbrella organization, and I'll tell you how in a minute, and our plans for the future, and Tobin will tell you more about that, to promote inter-organizational collaboration. And we're not looking to replace any organization or take funding away from them. We're just surveying what the needs are and focusing in on those needs and developing collaboration between those organizations and helping them do their work as well as possible. So how are we doing that? So I'll give you a little background. As you know, over the past 50 years or so, there's been massive investment from the global north in the global south for international development. And as a result, developing countries have created low-cost, innovative approaches to community health that are just phenomenal. And we have a lot to learn from what they've done through this investment. It's a concept called reverse innovation. So that's exactly what Migrant Health IL is doing. We're applying these low-cost innovations and adapting them to our context here because they're very effective and very low-cost. And what more could you ask?
The first project that we actually started, even before Migrant Health IL was an organization, was recognition that the sort of clinical status of continuity of care in the refugee clinic was a total ball of yarn. It was really difficult. A patient would come in, their file would get saved into a Word document, which was saved under a file, which was their ID number starting with 1 and working its way up until 7 or 8,000. And they would be moving these files around the clinic on USB sticks, and they would get lost, or you'd have 4 or 5 patients with the same ID number, and it was just absolutely impossible to keep track of anybody. So what we did was we implemented an electronic medical record system. We imported what data that we could from the Word documents. Fortunately, they had a reasonably good patient ledger, and we put those all into database form, and it's a web-based system. And I don't say web-based like we could access it from here, but within the clinic, all of the computers can access this web-based system. And the goal of it was twofold. One, it was to improve the continuity of care, improve the workflow through the clinic, so we can move people efficiently from nurse to doctor and have all their vital signs flow with them, so that when the patient came in, we don't have to retake a full patient history. We can simply just open up their file and say, oh, this guy was here last week with gastroenteritis. Let's ask them about that first and see if that's what's actually going on with them. And then the second purpose of this system is for data collection, because there's really a lack of knowledge about what are the needs of this community. Is it that there's a huge prevalence of COPD, or is it that there's a huge prevalence of TB? It's just basically unknown. And trying to connect some of these dots so that the clinic, both the refugee clinic that we're working with, as well as just the wider support system for refugees in Israel and migrants in Israel, can better tailor its programs to that.